Good evening, sir.
Good evening.
Sondanilla, sir.
It's very good. I will start.
Yes, sir.
Okay. So, good evening to all of you. As usual, we'll start with the ultra short case today. This case was day before yesterday. Okay, is my screen visible?
Yes, sir, it's visible.
Okay. So, this is a story of a 9-year-old boy. He was brought with a complaint that he takes long time to get up from bed in the morning. Once he gets up, he can walk without much problem. Similar problem in getting up from the sitting position. This has been there since early childhood. This is the patient's video. He seems to slightly bulky muscle, also in the lower limb, calf and thigh apex little bulky. Mild weakness of the deltoid. Biceps are muscles appear normal. He could overcome it, but seeing the age, it may be normal. Biceps is normal. Finger grip is good. Tight. Lower limb power up is normal.
सीधा में
Pulses are all normal.
No pain. Okay, lie down. Again, get up.
This has to get up repeatedly.
Lie down again. Slowly get up. That's called infant Hercules. So maybe it's okay.
It has to get up from squatting position.
Get up. Again do that. Repeat it. Then again. Get up. Now again. Now. Do it fast.
Now you can do it fast.
Good.
Okay, what do you think is likely diagnosis in this patient?
Thompson's disease.
Paramyotonia, sir. Thompson.
Is it paramyotonia or myotonia?
Myotonia congenital.
It's a param.
No.
It's not a paramyotonia will worsen with exercise. What I seen with congenital myotonia, it's ordinary myotonia. So I will show another fellow. This boy also came with difficulty in elevating his arm. That is his complaint. No myotonia, nothing. No.
Okay.
The arms and all. Repeatedly doing.
Okay. Ini lah, kayak bekas begitu deh, ya selesai. Siap begitu. Okay. Terus lah. Ini bekas. Betul itu. Betul. Betul. Ini bekas. Betul. Ini bekas. Betul. അതിനെ പൊക്കെ അപ്പൊ ഒന്നുമില്ലേ അതിന് പൊക്കെ ശരിക്കും പൊക്കെ ആ അതിന് പൊക്കിക്ക് പൊക്കി പിടിച്ചേ പൊക്കി അവര് പിടിച്ചോ.
See, this is Dr. Jacob, which is with me at that time. So that means in myotonia, it may come to you with a complaint of weakness. Remember this point. It's actually not because due to the weakness per se, because of the failure of relaxation, you got increased time to do the act. So I have to ask the person repeatedly doing this activity, then the myotonia wanes off, and then the apparent weakness become normal. So always make it a point to repeat activity to rule out the possibility of a angelic myotonia. Look at this. So what do you want to do in this side? This is let's come to this side. You can see the myotonia and myotonia. Myotonia is positive. It's also the thumb. Also there is. Okay. What does this boy have?
ഇനി കണ്ണ് മുറുക്കി അടച്ചേ നീ വിട്ടേ വിട് ഇനി അടച്ചേ വിട് അടച്ചേ വിട് അടച്ചേ നീ വിട് 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 അടച്ചേ വിട് അടച്ചേ വിട് അടച്ചേ വിട്.
So what is the diagnosis here?
Myotonic
This is paramyotonia.
Yes.
But because the myotonia worsens on repeated exercise. This boy had hyperkalemic periodic paralysis. So I'll go to the proper case now.
So why can't we do blepharospasm, sir?
It's not blepharospasm. It's not a spontaneous activity which is going on. It is, we are asking the patient to close the eyelids. He has got difficulty in closing it. Repeatedly doing either improve or disappears. If it's true myotonia, it will improve. On paramyotonia, it worsens with the repeated exercise.
Can you show the videos, sir, once?
Yeah, please, surely. Okay. This is patient spontaneous, not spontaneous contraction of the orbital iris oculi. I'm asking to close the eye. I'll show you. I'm asking to close. Close tightly. Each time, it becomes progressively the pupil is narrow. Unlike the previous child, where the weakness improved with exercise, here the weakness worsened with exercise. That's the difference between true myotonia and paramyotonia.
So how to differentiate from myotonic dystrophy?
Myotonic dystrophy is myotonic phenomena is there, just like ordinary myotonia, not paramyotonia, but there are other features, dystrophic features. Dystrophic features means they have progressive wasting and weakness of certain group of muscles, and associated features like somatic features like frontal baldness, cataract, testicular atrophy, classical facies, and weakness of distal muscles of the upper limb and lower limb.
Myotonia will be same like this.
Myotonia is same like the ordinary myotonia, but myotonia is not at all prominent in myotonic dystrophy. Somebody's myotonia may not be clinically seen at all because of prominent weakness. Unless you do EMG, you may not be able to pick up the myotonia.
Sir, is there a condition called myotonic dystrophy with QT prolongation? Sudden. Anderson syndrome something.
Anderson syndrome, I don't know, myotonia is there. I'm not very sure about it. Anderson syndrome, that is QT prolongation. Is it myotonia or something else? I don't know. I don't think this might be Anderson syndrome.
Yes, sir.
Okay, we'll go to the long case now. Okay.
Okay.
Any other doubts in that case? Okay. So this is a story of a 57-year-old female. She noticed recurrent hiccup and tendency to fall to the left side for the last 15 days. 5 days back, she noticed burning pain on the left side of the face and difficulty in swallowing and diplopia. Diplopia is binocular and is present in all directions. Only you see this much. Recurrent cough and tendency to the left side for 15 days. 5 days back, she noticed burning pain on the left side of the face, typically in swallowing and diplopia. Diplopia is binocular and is present in all directions of the face. So go to the finding. There's another history. 3 years back, she had developed acute onset of numbness of the right side of the body, for which she was admitted in the same hospital and was put on treatment. However, she never came for follow-up after discharge. She is not a diabetic or hypertensive. So I forgot to mention this courtesy to Charvida and Dr. Siddharth, who were the PG students in medical hospital. They showed me this case. Okay, this is a story. 3 years back, I developed acute onset and numbness of right side of the body. Not diabetic. I'll show the video of the patient. This is the video.
ಬಲ ಸೈಡ್ ನೋಡಿ ಅಮ್ಮ ಬಲ
So,
ಸೈಡ್
There,
ಎಡ
other
ಸೈಡ್
side,
ನೋಡಿ ಎಡ ಸೈಡ್
right side,
ಬಲ ಸೈಡ್
right.
ಬರಲಷ್ಟೇ
looking down,
ಕೆಳಗೆ ನೋಡಿ
Up,
ಮೇಲೆ ನೋಡಿ ಕತ್ತಿ ಎತ್ತಬಾರ್ದು ಮೇಲೆ ನೋಡಿ
ಅಷ್ಟೇ
ಫುಲ್ ನೋಡಿ ಮೇಲೆ ಲೈಟ್ ನೋಡಿ
okay. Is there a, either
ಬಲ ಸೈಡ್ ನೋಡಿ
to the right side, left side.
left side? Okay. Your
ಕಣ್
side,
ಗಟ್ಟಿ ಮುಚ್ಚಿ
cut much.
ಗಟ್ಟಿ ಮುಚ್ಚಿ
You close the eyes tightly.
ಅಮ್ಮ ಇದು ಮೇಲಕ್ಕೆ ನೋಡಿ
Look up.
ಹಾ.
This is not indicates on the right side. Show your teeth. E.
Show the-
E.
show the-
E.
So the
ಕಣ್
teeth.
ತೋರ್ಸಿ ಅಮ್ಮ
That's also more moving. Okay.
Or is normal.
ಹಲ್ ಕಚ್ಚಿ
Okay.
You see, he had LM and patient diabetic weakness on the left side, which you can see clearly.
Put out
But it
your
was there.
ನಾಲ್ಗೆ ತೋರ್ಸು
On protrusion, there is mild tongue deviation on the left side.
complete.
ಪಾಯಿಂಟ್ ನಾಲ್ಕನ್ನು ಆಚೆ ಈಚೆ ಬೇಗ ಬೇಗ ನಡೆಸಿ
Okay. Some deviation the tongue towards, not very. Some suggestion.
There is some cell-shaped tongue deviation on the left side.
Put it inside. Ask it to put completely out.
ಕಂಪ್ಲೀಟ್ ನಾಲ್ಕು ಹೊರಗೆ ತೆಗಿ
Is it same?
She's got decreased pain on the right forehead.
ವ್ಯತ್ಯಾಸ ಉಂಟಾ ಅಮ್ಮ
ಇನ್ನೊಂದ್ಸರಿ ಚುಚ್ಚಿ ನೋಡೋಣ ಈ ಕಡೆ ಸ್ವಲ್ಪ ಚುಚ್ಚುತ್ತೆ
Decreased.
ಹ್ಮ್.
Okay.
ಈ ಕಡೆದು ಜಾಸ್ತಿ
ಜಾಸ್ತಿ,
ಚುಚ್ಚೋದು
okay.
ಜಾಸ್ತಿ ಚುಚ್ಚುತ್ತೆ ಅದು ಮೆತ್ತಗಾಗುತ್ತಷ್ಟೇ
ಹೌದು.
ಹಿಂದೆಲೆ ಅದು ಅಷ್ಟು ನರಗಳೆಲ್ಲ
ಹಾ, ಇದೆಲ್ಲ
No.
ಈ ಚುಚ್ಚುದು ಕರೆಕ್ಟ್ ಚುಚ್ಚುದು ನೋವು ಆಗ್ತಾ ಉಂಟು ಹೇಳಿ
This one.
That is equal.
This one different.
ಅದು ಅದು ಒಂದೇ ತರ ಉಂಟು ವ್ಯತ್ಯಾಸ ಉಂಟಾ
It's equal both sides.
ಅರ್ಧ ಉಳ್ಳಿ ಎರಡು ಒಂದೇ ಥರ ಉಂಟು
Okay.
ಆ ಎರಡು
ಯಾವ
ಈಗ ಇಲ್ಲಿ ಚುಚ್ಚುದು
ಇದು ಸ್ವಲ್ಪ
It's decreased on the right side of the face.
ಇದೊಂದು ಚೂರು ಕಮ್ಮಿ ನೋಡ್ರಿ ಇದಿಷ್ಟು
Got it. This face with this one.
ಬಲ್ಗಡೆ ಕಣ್ಣು ಪ್ರಾಬ್ಲಮ್
Ek और this
ಅದು
one.
ಚುಚ್ಚುದು
ಚುಚ್ಚಿದ್ರೆ
ಅದು
ಗೊತ್ತಾಗುತ್ತೆ
ಚುಚ್ಚುದು ಒಂದೇ ತರ ಉಂಟಾ
ಅಯ್ಯೋ, ಅಲ್ಲಿ ಭಾಳ ನೋವುತ್ತಲ್ಲಿ
ಎಲ್ಲಿ ಬಾಳ ನೋವು ಉಂಟು?
ಚುಚ್ಚಿರಲ್ಲ
ಎರಡು
ಭಾಳ
ನೋವು
Limbs, there is no difference in the pain between the limbs.
ಒಂದೇ ಥರ
Same.
Adjust.
Hold it tight.
Or is grossly normal.
ದೃಷ್ಟಿ ಮಾಡಿ.
Okay. Leave it. I said.
She had mild incoordination of the limbs, very mild incoordination, if at all.
दूसरा दूसरा.
ಎಡಗೈನ
Yeah. Yeah.
ಎಡಗೈ ಬರಲ್ಲ
Yeah. One second.
ಎಡಗೈ ಬರಲ್ಲ ಏನಾರ ಮಾಡಕ್ಕೆ ಹಂಗೆ
For some incoordination.
ನಾ ಇಡಕ್ ಹೋದಾಗ ಒಂದು ಒಂದ್ ಕಡೆ
It's
ಹೋಗತ್ತೆ
catching them. This hand. This hand.
ಆ ಕೈ ಮಾಡಿ ಮತ್ತೆ
Yeah.
ಮಾಡಿ ಮಾಡಿ ತೋರಿಸಿ
That is correct. Okay. Did you see the incoordination?
ಬಿಡಿ
They must close the eyes and open.
ಎರಡು ಕಣ್ಣು ಗಟ್ಟಿ ಮುಚ್ಚಿ
Open. बंद करो अम्मा. Open. बेरल नोडी.
You looking to the left side.
ये नोडी.
ಕಾಣಲ್ಲ
हाँ. चल ये नोडी. बेरल नोडी अम्मा.
ಕಾಣುತ್ತೆ
नोडी अम्मा. नोडी.
ಮಬ್ಬು
नोडी.
ಜಸ್ಟ್ ನೋಡಿ ಅಮ್ಮ
ಅದೇ ಮಬ್ಬು ಇದು ಕಾಣ್ತತೆ ಆದ್ರೆ ಮಬ್ಬು
Notice. Left eye showing abdomen nystagmus, right eye are acting less.
ಭಾರಿ ಕುಕ್ಕುತ್ತೆ
Did you see that?
Yes.
Okay.
ಬೆಳಕು
You understood?
Yes.
You ask her to close the eyes and open.
Close.
The processes were all normal. Bladder left was subgoing. Okay, let me see letters going out. Yeah, letters going right to a flexor.
Being kind of the left side.
Vibration is present equally on both sides,
Manda?
but it has decreased in both the lower limb.
ಇಲ್ಲ.
He says she's not able to feel up to the machine.
ಅದೇ ಅಂತ ಇಲ್ಲ ಏನು ಅಲ್ಲಿ ಅಂತ ಇಲ್ಲ
ನೆಗಡಿ ಡಯಾಬಿಟಿಕ್
ಕೈ
She's able to feel over the knees, not below that.
ಈಗ ಉಂಟಾ
ಇಲ್ಲ ನನ್ನಲ್ಲ
ಹೇಳಿ
ನಾವು
ಈಗ
ಕೆಳಗೆ
ನಾವು
She's able to stand normally in the upper limb,
ಮೇಲೆ
but impaired over both toes.
ಕೆಳಗೆ ಕೆಳಗೆ ಮೇಲೆ
ಅಭಿ
ಈಗ
ಕೆಳಗ ಮೇಲೆ
ಕೆಳಗಂದಿದ್ದೀರಾ
ಅಭಿ
ಕೆಳಗೆ
ನಾವು
ಮೇಲೆ
2 steps ಮಾಡಿ
And on stand, she tends to fall towards the left side.
ಓಕೆ ಓಕೆ ಸ್ಟ್ಯಾಂಡ್ ಲೈಕ್ ದಟ್
ಕಾಲ್ ಜೋಡಿಸಿ
ಜೋಡಿಸಿ
ಹಾಗಾದ್ರೆ
ಸ್ಟ್ಯಾಂಡ್ ಲೈಕ್ ದಟ್ ಯು ಫಾಲ್ ಟುವರ್ಡ್ಸ್ ಲೆಫ್ಟ್ ಸೈಡ್ give it give it ma
ಕೈ ಬಿಡಿ
ಕೈ ಬಿಡು
then பிடிச்சுக்கலாம் with feet closed forward towards the side.
You want to see the video once again? I can show. Otherwise, what are the findings in this patient? It's a difficult case.
Sir, she has 1.5 syndrome on the right side,
Very good.
and she also has 11 seventh, and the trigeminal tract is affected on the right side. 10th also affected, and
And this affected on the left side.
10th is affected on the left side, sir.
Left side, yeah.
Okay, okay. And she has got a contrapulsion to the left side. It's a contrapulsion to the left side. And the sensory finding in the lower limb, was it on the same side or opposite side, sir?
Sensory find in the lower limb on both sides, both lower limb, below mid shin. They're only in vibration and joint sense. Otherwise, pain is normal in both the lower limb.
Why vibrations lost on both sides, sir?
Only vibration, both feet up to mid shin, as well as joint sense.
That that could be the lateral limb also affected. I mean, the
The pain is normal.
pain is now. And she has got an ataxia also on the left side. That could be part of a
Mild incoordination. Yeah.
yeah. Maybe superior cerebellar peduncle also affected on the left side. And there's a MLF lesion also there. MLF as well as the gaze center also affected. So we have to invoke the corticobulbar and multiple cranial nerves, the tracts, and
Okay. So you have postulated where will be a site of lesion in this patient.
condylation on the right side. But a single lesion, maybe in the midline, it is crossing to the opposite side.
Is it midline or pons or where you would like to postate?
Pons on the right side would be my first.
Okay.
Medulla also, sir. Many of the bulbar symptoms and the history is history of hiccups and also 12th is suggestion of partial involvement.
No, I didn't get you. Can you tell that once again?
Sir, maybe some bulbar involvement, medular involvement. The history suggestion of hiccups and also the 12th nerve involvement. It will be a medular involvement also should be suspected.
Right. Middle involvement where on the right side or left side?
Right side, sir.
The tongue where the partial weakness is on the left side. Okay, I will show you one finding. Your all findings are all correct. But just look at on the part of the video. Do you remember I asked the patient to close the eyes and open 2-3 times? Did you notice that thing? Why did I do that? I'll show that.
Full complete. Full complete.
That one.
ಈ ಕಡೆ ಸ್ವಲ್ಪ ಜಾಸ್ತಿ ಚುಚ್ಚುತ್ತೆ
ಇದು ನೋವು ಆಗ್ತಾ ಉಂಟು
ಇವತ್ತಿಗೆ ಸ್ವಲ್ಪ
ಅಲ್ಲಿ ಚುಚ್ಚು
This.
I'll show that video. I don't know which.
ಅಮ್ಮ ಇದು ಮೇಲಕ್ಕೆ ನೋಡಿ
This one same.
This is not going to decrease on the right side. Show your teeth. E.
ಹಲ್ ತೋರಿಸಿ ಅಮ್ಮ
That's also more moving. Okay.
ಹಲ್
Tight.
ಕಚ್ಚಿ ಹಲ್ ಕಚ್ಚಿ
Okay. That is the left hand. Okay. Put out your tongue.
ನಾಲ್ಗೆ ತೋರಿಸಿ
Full complete.
ಫೈನ್ ನಾಲ್ಕನ್ನು ಆಚೆ ಈಚೆ ಬೇಗ ಬೇಗ ನಡೆಸಿ
Okay. Some deviation the tongue towards, not way. Some suggestion.
ಟುವರ್ಡ್ಸ್ ಲೆಫ್ಟ್
Put it inside. Ask it to put completely out.
ಕಂಪ್ಲೀಟ್ ನಾಲ್ಕು ಹೊರಗೆ
Is it same or different?
And touching that part of the video where I showed the binding.
ಒಂದೇ ತರ ಬುಲ್ಡಿ
It's the last part.
Is it last part? Okay.
The last.
ಉಂಟಾ
Okay. Leave it. A second. Better no.
This one.
Open.
Did you see that? I think first at the beginning also I did that. I showed that.
ಬಲ ಸೈಡ್ ನೋಡಿ ಅಮ್ಮ ಬಲ ಸೈಡ್ ಎಡ ಸೈಡ್
Right side.
ಬಲ ಸೈಡ್
Right.
ಬರಲಷ್ಟೇ
Niche.
ಕೆಳಗೆ ನೋಡಿ
Up.
ಮೇಲೆ ನೋಡಿ ಕತ್ತಿ ಎತ್ತಬಾರ್ದು ಮೇಲೆ ನೋಡಿ
ಅಷ್ಟೇ
Okay. Is there a either?
ಬಲ ಸೈಡ್ ನೋಡಿ ಗಟ್ಟಿ ಮುಚ್ಚಿ
Cut much.
ಗಟ್ಟಿ ಮುಚ್ಚಿ
Never close.
ಅಮ್ಮ ಇದು ಮೇಲಕ್ಕೆ ನೋಡಿ
This is not going to decrease on the right side.
Right side lag up almost, sir.
Let's say because the
The
element
jerky movement of the left eye once in my opening.
Right.
ಹಲ್ ಕಚ್ಚಿ
Okay.
very that thing
That is the left hand. Put out your tongue.
ನಾಲ್ಗೆ ತೋರಿಸಿ ಫೈನ್ ನಾಲ್ಕನ್ನು ಆಚೆ ಈಚೆ ಬೇಗ ಬೇಗ ನಡೆಸಿ
Some deviation the tongue towards, not way. Some suggestion. Put it inside. Ask it to put completely out.
ಕಂಪ್ಲೀಟ್ ನಾಲ್ಕು ಹೊರಗೆ ತೆಗಿ
Is it same or different?
ಎರಡು ಉಂಟಾ ಅಮ್ಮ
ಈ ಕಡೆ ಸ್ವಲ್ಪ ಚುಚ್ಚು
Okay.
ಅಷ್ಟು ನರಗಳೆಲ್ಲ
This one. Different.
ಎರಡು ಒಂದೇ ತರ
ಈಗ ಇಲ್ಲಿ
ಕಮ್ಮಿ ನೋಡ್ರಿ ಇದಿಷ್ಟು
This one.
ಬಲ್ಗಡೆ ಕಣ್ಣು ಪ್ರಾಬ್ಲಮ್
I just that part of the video searching for it.
ಬೇಗ ಬೇಗ ಮಾಡಿ
Move.
ಆ ಕೈ ಮಾಡಿ ಮುಚ್ಚಿ
See what is happening now. Look at the video once again. I'll show it once again.
Did you see it?
ಬಿಡಿ ಕಣ್ಣು ಮುಚ್ಚಿ ಎರಡು ಕಣ್ಣು ಗಟ್ಟಿ ಮುಚ್ಚಿ
Look carefully. See what is happening to the left eye. Did you notice that thing?
Bell's phenomenon is visible, sir, on the right side.
No. Look at the eyeball movement when I open the eyes. It's right element facial palsy. That Bell's phenomenon maybe they're not closing.
Sir, she has ipsy-pulsion.
Good. That's the video once again. Okay. That's the video. Look very carefully. On closed eyes, left eye is deviated. That now this again. Look at again.
ಕಣ್ಣು ಮುಚ್ಚಿ ಎರಡು ಕಣ್ಣು ಗಟ್ಟಿ ಮುಚ್ಚಿ
See, he is coming back to the middle line. Did you see this? Okay, did you see that? Already with the under closed eyes, the left has been gone on to the left side, left lateral portion of the eye. Okay, and left it tendon of involvement, and she got burning pain on the left side of the face also. So these things point to what? And left sided incoordination. Lateral portion.
Points to lateral medullary.
Yeah, that points.
Medulla.
Medulla, correct. Okay, she's got a lateral medulla. I agreed with that, but let's explain everything in this patient.
She also has medial medullary problems, sir, because of 12th nerve involvement.
Okay, then I'll come to that. 12th now could be middle medullary also, but there is some explanation for that. I'll come to that. Now, what is happening to the right side? He has got a right case palsy, correct? You see that right case palsy, the very beginning, and right element facial palsy, and right IN. You are not seeing that else that part, but see the eye movement, but as Umar was telling. She's not able to do the right side.
ಬರಲಷ್ಟೇ
No, okay. Up, okay.
ಮೇಲೆ ನೋಡಿ.
See, on to the left side,
Okay, is there a either
ಬಲ ಸೈಡ್
right she could not. See,
Left
right
side.
is adduction is less.
ಗಟ್ಟಿ ಮುಚ್ಚಿ.
Adduction is less and abduction and it shows nystagmus.
ಅಮ್ಮ ಇದು ಮೇಲಕ್ಕೆ ನೋಡಿ.
this is not increase on the right side. Show your teeth. E color E.
ಹಲ್ ತೋರ್ಸಿ. ಮುಷ್ಟಿ ಮಾಡಿ.
Okay, leave it.
ನೋತಲೆ
ಎಲ್ಲಿ ಬಾಳ ನೋವು.
Hold it tight.
The adduction nystagmus on the left side, adduction failed on the right side.
ನೋಡಿ
ಕಾಣಲ್ಲ
okay ಏನು ನೋಡಿ ನೋಡಿ ಅಮ್ಮ ನೋಡಿ ಅಮ್ಮ ನೋಡಿ
ಮಬ್ಬು
ಜಸ್ಟ್ ನೋಡಿ ಅಮ್ಮ.
ಅದೇ ಮಬ್ಬು ಇದು ಕಾಣ್ತದೆ.
Then abducted nystagmus the left eye.
notice left eye showing abdomen nystagmus, right eye is adducting less.
The abducted nystagmus.
Did you see that? Okay, you
ಬೆಳಕು
understood.
So there has to be two sides of lesion here. One, as Sumaru was telling, right pontine lesion, which can explain the element 7 and abduction nucleus on the right side. And it's also got pain, decreased pain on the right side of the face. And what is the site of lesion will come later on. Secondly, he has got a left lateral involvement because of the ipsy portion of the left side, left tenthiner palsy. Then you have to think of lateral and left side coordination. Okay. Now, question number 1. Is the gaze palsy to the right side is due to the abducent nucleus involvement or due to the PPRF or the lesion above that? What will you do to differentiate the two on the left side? Before that, I'll tell the findings before. No Horner syndrome. There is no movement of eyes to the right side. On looking to the left, the right eye does not seem to adduct fully. There is sustained nystagmus to the right eye. Saccadic lateral pulsion to the left. Decreased pain in the right half of the face. Right element facial palsy and left tenthiner paralysis. Mild tongue deviation to the left and protrusion. Okay. Now, motor system, tone power normal, ETR all normal, plantar left abdomen. Sensory impaired vibration of both lobes machine, stands lateral pulsion of the body to the left. Now the question is the decreased pain on the right? This is the first question. Is got decreased pain on the right side of the face due to right? Is it due to the right descending nucleus tract involvement or left ascending endothalamic tract affection? You got the point. See, he has got a left lateral lesion, which can cause decreased pain on the right side as well, because of the ascending endothalamic tract involvement. Or the right pontine lesion must have affected the descending nucleus.
Corneal reflex.
Very good, very good. If it is corneal reflex is absent, means that it cannot occur with a lesion ascending endothalamic tract. On the other hand, if the descending nucleus is affected, the cornea will be absent. So if the right side was the culprit, causing the decreased pain on the right face, the right corneal reflex should be absent. On the other hand, if the left lateral lesion is the culprit, the right corneal reflex will be normal. Okay, understood? Because the corneal reflex pathway, it descends up to the spinal nucleus and cross and go to the something nucleus. Does not ascend in the ascending endothalamic. So that's the point to differentiate the two. Very good. So this is done. Corneal reflex was done. It is normal. Let's say also normal.
ಮೇಲಕ್ಕೆ ನೋಡಿ.
There is no difference in the corneal reflex. So what does it tell you? The right side of the loss of pain is due to what? Left lateral vein involved in the medial part of the lateral medulla, but the ascending endothalamic tract is affected, not due to the descending nucleus is affected.
Okay.
I'm not sure whether you're following me or not. Lattice syndrome, you can have left corneal reflex loss due to the descending nucleus involvement or descending part of the trigeminal involvement. Okay. Left lateral lesion can produce loss of pain on the right side of the contralateral face, where it is due to the endothalamic tract on the right side is affected on the left side after crossing. If the endothalamic tract is affected on the left side, causing pain loss on the right side, the right corneal reflex will not be affected. Is it confusing? I can show the diagram of that thing.
Yes, sir, please, sir.
The diagram just means I did not copy the diagram. So it is there in the laptop. Anyway, I'll make it simple, more. Just 1 minute, I will take that thing and come back to you. Anyway, I think at the end of the class, I will let you know. Okay.
Sir, in this case, the corneal reflex present on the right side, no?
Corneal is present on both sides equally.
Both. Okay.
Okay. Now I'll explain it once more. Now imagine right side of the. This is my right side and this is the left side. Okay. The pain fibers on the left side of the face descend down the descending tract of trigeminal nerve and into the spinal nucleus at various levels. Okay. From there, it goes to the opposite side and ascend contralaterally in a tract called ascending endothelium. So that goes to the thalamus on the right. That's the pathway for the pain fibers from the face. Okay. If the lateral medullary is patient has got decreased pain on the right side of the face in this patient, forget about that particular patient. Imagine that patient has got lateral medullary syndrome. The descending nucleus is affected on the left side. The pain loss will be on the left half of the face, as you already almost always have seen. That patient will have this corneal reflex on the left side because the affected lesion, the lesion is affecting the descending nucleus and the tract. So the corneal reflex will be absent because corneal reflex fibers descend up to the lowermost part of the spinal nucleus and then cross and go straight away go to the seminal nucleus on both sides. It does not cross the opposite side or not go to the ascending endothalamic. Ascending endothalamic tract goes to the thalamus for your pain perception. Okay. Similarly, a left lateral lesion can also cause contralateral pain loss in the face. That is because on the other side, on the right side of the face, the pain fibers similarly descend in the spinal nucleus and cross to the opposite side, ascend on the left side. That location, the ascending endothalamic tract on the left side is medial to the descending nucleus. So if that is affected, again, you can have loss of pain, but this will be on the contralateral face. Okay. If the ascending endothalamic tract is responsible for the pain loss, then corneal reflex will not be affected. Okay. That is why you look for the corneal reflex differentiate. Because in lateral medullary syndrome, there are various types. They can have ipsilateral loss of pain sensation, contralateral loss, or both can, whole face can be affected. Depending upon even on one-sided lesion, because if the same tract is affected, on the same side. Ascending endothalamic tract affected will be opposite side. Both are affected, all the face will be affected. Anyway, in the next class, I will show them. I got all the diagrams of the various types of presentation lateral medullary syndrome, stop for type 1, type 2, type 3, and pseudospinal loss. All I will explain later on by showing the diagrams. Now, if I escape now, it will be difficult to continue with the part. Okay, next time we'll definitely show that. So lesion is causing pain loss on the right side is on the ascending endothalamic tract. Now, what is the site of lesion causing gaze pulse to the right side? Is it abducing nucleus or the PPR? Pardon? Pardon? How to
Vestibular reflex.
Okay, very good. Vestibular reflex. So, do the vestibular reflex. So, as the patient look at the finger, ER is absent towards the right side. Moving well to left side, but not to the right side. So that shows that he's got a PPRF, not PPRF, or the frontal mesencephaly pathway is affected. It is to the effect of the abducing nucleus per se. So, where do you want the? So, this is the abducing nucleus. Other point favoring the element, abducing nucleus, the element facial pulse. You know, the 6th nerve nucleus and 7th nerve fibers comes close together because the 7th nerve fibers loops around the abducing nucleus. So when the 6th or the case when abducing nucleus and 7th comes close together, affiliate together, always think of an intra-medullary lesion. So right case palsy with plus INO, right one and a half syndrome. And this is the location. See, this is the abducing nucleus on the right side, which supplies the lateral rectus on the same side, as well as cross and nasal supply the middle rectus. Similarly, this is a PPRF on the left side, supply the left abducing nucleus. It supplies the same side lateral rectus, or the opposite side, and that's the middle rectus. In our patient, the lesion is here, where it has affected the abducing nucleus on the right side, causing the right case palsy with absent VOR, and the MLF is affected on the same side, causing the adduction failure on the right side. And so, so this is our one-and-a-half syndrome. Now the question is, can you explain everything with the right side? No. And the right pontine lesion, left lesion. What is it like? Now let's see the other possibility. As somebody was pointing to whether there is a possibility of left medial medulla involvement also, because there's got a tongue deviation protrusion. Okay. First, we have to decide whether the protrusion tongue is human or LM. In this case, is it human or LM?
Mostly upper mortem, sir.
Upper mortem. Why do you say so? You are correct. Because there is only a mild protrusion, that too only protruding the tongue. It has no deviation of the tongue inside the mouth. Inside the mouth, there is no deviation. On protruding, it is moving towards the left side. That covers a human lesion. Okay. That means the left genial process is affected. Muscles separated by the tongue is not affected. It's likely to be human. Another point favoring human lesion is that a left plantar is outgoing, not the right plantar. So these two cannot be absolutely certain whether it is a medial medulla is affected or not. But the presence of femoral sense on the left side and absence of tongue deviation inside the mouth only on protrusion makes me think most likely due to the left part of the left cortex bulbar, because she has got the right pontine lesion anyway. Okay. So likely, what is likely etiology in this patient?
Sir, what about the vibration sense impairment in the feet?
Okay, that cannot be explained by either these two lesions at all. Because if it is a posterior column involvement, it can, but they are more medially situated in the spine. These are all lateral situation. The 7th nerve, gaze pulse, lateral pontine, and lateral mental. They are situated in the medial portion. It's a little difficult to explain why the vibration is lost in the patient. You see, I asked whether it's a diabetic, she's not a diabetic.
Okay.
So left 10th also, sir.
She has got left hand. I couldn't see, I know, I couldn't see it in the video. And
the localization for that one.
That is the left lateral medulla. So the patient left lateral medullary syndrome as well as right lateral pontine syndrome.
Is it recurrent demyelination or some cavernoma like this?
No, this occurred in a 2 weeks gap. 1 on 1 cavernoma and all occurs recurrently on the same set. Same cavernoma is in the same bleed look at the same location. It is one on the left side or on the other side. Could be infarct.
Recurrent vertebral stroke, sir.
There's a possibility, or it can be demyelination, but it is 50 plus, but not a diabetic or hypertensive. So, what investigation need?
MR with MR angio, sir.
Okay. MR angio was normal. It's not. This is MRI. This is clear. There is right pons and left medulla. Medulla and left upper cervical cord also. Okay. Subject plantar could be due to the left side of the spinal cord itself. So the video once again. That is one side, the right side of the pons. This can explain the PPF, obtuse nucleus involvement as well as the right element facial palsy. Okay. Going forward, this is the left lateral medulla. You can see that the inferior cellular peduncle is affected. Not only that, it is also affecting the cord, not only left side but also to the right side. So it is not fitting with the vasculated. It is going to the right side. See, it's also affecting to the right side. I'll go to the next one. Same thing. Adjust the window width and make it more clear to you.
That's right.
This is the deep. This is like cord, lower medulla. This is diffusion. There was no corresponding hypointensity in ADC. ADC was a poor quality, so I am not bringing it. I am not brought it.
Bring it down.
This is cervical cord.
Because he has
It's a appendix.
This is the first time when she came.
This is mild atrophy of the upper cervical cord as.
No, sir, this is the this one only. This
So it's slightly thin compared to the lower part. This head is slightly thin out.
This is the first time when she came.
no, sir, this is not.
Dorsal cord is
The
normal.
previous one.
No, sir, this is the this only. This.
Axial cervical is okay, nothing. It's the uppermost part. Is the contrast scan done now? There is no contrast enhancement. Okay, this is cervical. Okay, now what is the diagnosis now?
NMO, sir.
NMO.
So one is NMO. I'll come back to the history once again. No, in fact, she had 3 years back, patient had numbness of right side of the body. I told you the past history. That is very significant in the patient. Because the MRI was done 3 years back. This is shown here. This is hyperintensity in the cervical cord now.
old one. Okay.
You see the corresponding cut. That is where it's filling the whole of the cord mainly onto the left side. It's more than 3 segments.
Brainstem involvement was not there.
Not there.
3 years back, there was no brainstem involvement at all.
That
At that time, brain MRI was normal.
Can you scroll it down? I want to see the full screen.
This is the contrast and contrast enhancement.
It's a present one.
no, no. Previous one.
Previous one. This previous one.
Previous
No,
one.
no contrast.
So, what is the likely diagnosis?
NMO.
More like NMO. See, in the previous admission, both NMO, MOG were done, both were negative. So, we have sent it recently, I got second now. Okay, so most likely it's recurrent demyelination. Maybe antibody negative MOG or NMO, NMO spectrum disorder, but even antibody negative NMO. So, any questions?
Sir, can't we explain the posticular impairment?
Yeah, that is because of the residue of the old lesion. The patient had hyperintensity bilaterally previously, even though she said numbness on one side of the body, we have not seen the patient at that time. She must have had involvement with the posterior column at that time. Even MRI also shows mainly the posterior part is on. So that must have been responsible for the loss of vibration and conscious in both patient. That cannot be explained by your present left lateral ray and right lateral condensation.
Sir, should we investigate for secondary cause of demyelination in view of age, sir? Age is against NMO.
NMO can occur also in this age group. Secondary cause means what do you have in, I don't know.
In vasculitis, Beckett's and all.
Yeah. Okay, that's of course that should be done. But it's less likely because in the initial episode, 3 can remain asymptomatic for long and then developing. In fact, the patient was worked up initially for ANA and on initial admission, not this admission. And I had brought all the stress negative. ANA, serum protein, electrons, everything was negative.
Problem can be explained by the current cervical cord lesion. No?
Joy, can you treatment say, Joy?
Posterior column can be explained by bilateral posterior column, can be explained by the bilateral cord lesions now, no?
Yeah, can be explained. The patient had this bilateral involvement of posterior column earlier. Even now that can be explained because the lesion in the brainstem may be extending down to involve the posterior column. That also can be explained. Because lesions in the medulla coming down to the cord. That also can look at the picture back again. See, its lesion is here. See, that can be explained also. This is the present MRI. See, this cord is affecting mainly laterally, but here posterior also is affected. But she not completely numbness pressure lower limb this admission. That is the previous admission. Okay. I primarily bought this case for localization. Localization for is the why the if you look at the pain fibers affected on one side of the face, always help differentiate the side. When you get lateral gaze palsy, roll out PPRF or other things by palliative plus. That's the idea which I've been. And lateral syndrome, you invariably should look how the saccadic lateral pulsion. That may be the only sign of lateral syndrome. This is for, I think let's keep all these things, why the IPSC question is occurring in that. Okay, no questions, we got a second case.
Yes.
Now, this is a story of a 15-year-old diabetic old man. It's also a long case. His complaint started 8 months back as weakness of the right upper limb in the form of inability to lift his right upper limb. Evidenced by his inability to reach an object in the high shelf and difficulty in playing badminton. The weakness remained static since then. 8 months back. There's no pain or numbness and paresthesia. Is there one episode of transient loss of consciousness while riding the bike in minor accident? This is long back. On recovery after the few minutes, he was reported to show dysarthria, which lasted for a few minutes. No other complaints like any weakness or ataxia at that time, no GTC or incontinence. 1 week back, patient noticed numbness of the entire right side of the body with some change in the voice, which improved over the next few days. So the voice improved over the next few days, but numbness is persisting. No numbness over the face. So history once again. Complaint started as 8 months back as weakness of the right upper limb, elevating and something in the high shelf. And the weakness remained like that without any improvement or worsening and was sensitive. One episode of transient LOC 2 or 3 months back, while riding the bike ending in minor accident, on recovery after a few minutes of the loss of consciousness, he was reported to show dysarthria, which lasted for a few minutes. Now, 1 week back, patient noticed weakness of the right side of the body, will change the voice. So this is the video of the patient. Painless are all normal. It mild weakness of the right side. 4 plus power. Biceps was normal bilaterally. Very mild weakness. Biceps is normal on the left side, but weak on the right side. That is pretty weak. External rotators were normal. Internal rotators normal. Wrist extension says normal, but weak on the right side. Normal on the left side, weak on the right side. Finger extension says normal on the left side. Mildly weak or normal on the right side. Finger plexus normal bilaterally. Good power on the right side. Adductor pole is long as normal. Extensor pole is long as normal. That is normal. Flexor pole is long as normal. But see the wrist flexors is weak. It can easily overcome the wrist flexion. That is normal. I can easily overcome that wrist flexion. At the same day, finger flexors have good power. Wrist extension was also slightly weak. It's got a good power, finger flexors. That's also good power. But extensor pole is long as slightly weak. Because full weakness. Extensor pole is normal. mild weakness of interosseous or on the right side.
ഇത് തള്ളിക്ക്.
Also, I could overcome the left side as well.
Small vessels wasting well on vessel.
ഇങ്ങോട്ട് തള്ളിക്ക്. ഇങ്ങോട്ട് തള്ളി. തള്ളിപ്പിടി. ശരി, ഇത് പല്ല് മടക്കിക്ക്. നൂർത്തെ. നൂർത്തെ.
Wasting well.
Movement is positive on the right side, normal on the left side.
ഒന്നുകൂടെ പിടിച്ചോ.
Performance is positive.
ഇങ്ങനെ പിടിച്ച് ഈ തള്ള പറ്റില്ല പാടില്ല.
Mild flowing with the right little ear. Mild flowing is also present on the left little ear as well. Scapular muscles were normal, serratus anterior was normal.
മതി വിട്ടോ. എങ്ങനെ കൊണ്ടുവന്ന് മുകളിലോട്ട് വെക്കാം. തിരിഞ്ഞ് ഇങ്ങനെ വെച്ചോ. ഇടതേ മാത്രം പൊക്കി മുകളിലോട്ട് ഇങ്ങോട്ട് നേരെ നിൽക്കണേ കേട്ടോ. ഇതാത്തെ പൊക്കി
You can see the biceps is wasted, so wasting of the right biceps.
ഓൺ ചെയ്തോ.
Middle muscles were normal. Lower limb tone power normal.
കൊടുക്കണ്ടേ. ഇത് പൊക്കിക്കേ. കേട്ടോ. ഇത് മടക്കിക്കേ. ചവിട്ടി നൂർത്തെ. ഇത് ചവിട്ടി നൂർത്തെ. കാലം മാറും.
Lower limb muscles were normal. Plus supplements are all diminished, just not elicitable at all. I couldn't get into place in that.
അത്ര വേണ്ട.
Picture technique for the triceps are all absent. Abdominal pressure is absent. And lower limb pressure elicitable normally. Just one plus. Relax also one plus.
നല്ല കൈ മുറുക്കി പിടിച്ചേ. നേരെ വെച്ച്.
Sensations is normal. There is impaired pain. Lower limb is normal. Let's say impaired.
ഒരേപോലത്തെ. ഇനി ഈ കുത്തുന്നതും ഇതും തമ്മിലോ എവിടെ കൂടുതൽ?
It is decrease on the right lower limb.
ഇവിടെ കുറവ്. ഇതും വ്യത്യാസമുണ്ടോ? ഇനി ഈ കുത്തുന്നതും ഇതും
Decrease on the right side of the trunk. It is on the right upper limb.
ഇവിടെ കുറവാണ്. ഇരിക്കാണല്ലോ.
That's a level he will show you. On the there it's increased normal.
നോർമലായോ? ഇനി ഇതും തമ്മിൽ എടുക്കുകയാണെങ്കിൽ
That is normal, equally present.
ഒരേപോലെയാണോ? ഇതും ഒരേപോലെ. ഈ വെച്ചതും ഇതും
Equal. But decreased temperature also on the right side.
ഈ വെച്ച തണുപ്പും എന്താ വ്യത്യാസം? തണുപ്പില്ല. ഇവിടെ തണുപ്പില്ല.
There is no cold since it's the right side.
ഇവിടെ തണുപ്പില്ല. ഇവിടെ ഉണ്ട്. ഇനി ഈ വെച്ചതും ഇതും തമ്മിലോ?
In joint sense, normal. Even the little finger it is normal.
ഇപ്പൊ എങ്ങനെയാ? ഇപ്പോഴോ?
Lower limb is also normal.
ഇപ്പോഴോ?
Number is negative. Gait is also normal. So you can say mild was not very convenient, not normal. And the working is also mildly attached, but very normal for me. Turning around is okay, so we can take it as normal. So, summarizing the findings, stainless all normal. Motor wasting of the right triceps, right forearm and small muscles of the right hand. No wasting of the left upper limb. No normal in both upper and lower limb. Our right upper limb, posterior weakness of the right deltoid and biceps. Right biceps is certainly weak. And this point, wrist flexion, extension weak, more weakness for the wrist plexus. However, no weakness of the finger plexus, finger extensions going to be mildly weak. This weakness of the flexor process longus, longus and brevis, all thenar, hypothenar muscles, and interosseous adductor pollicis. But the part of the left upper limb, all normal, except for mild weakness of the hypothenar muscles, central and first interosseous. Lower limb, normal power. ATR, upper limb, all absent. Lower limb, knee check 1+, angle check also 1+. Abdominal plus absent bilaterally, plantar indefinite. No incoordination of upper and lower. Touch normal in all areas. Pain and temperature impaired over the right upper limb and right shoulder and right lower limb. Vibration GPS normal in both upper and lower limb. Stance negative, gait normal and lower limb. So, where is your localization and what is the possibility of it?
Lattice-spinothalamic tract and adrehorn cell on the C segmental distribution. C5 to C81.
So, permission things are right intermedullary lesion.
Yes, sir.
But in that case, the entire right side is affected, no? And from C5 to the whole right lower limb is affected. If on the right side, the lesion has to be extensive from top to bottom. If practice, the pain should have been caused on the
lattice-spinothalamic tract involvement on the right side also. That can explain the if it's extending to the right side. That can explain the lower limb also.
The point is, if spinothalamic tract is affected, pain loss should be on the left side. The pain loss is on the right side.
Sir, a segmental affection before crossing on the right side.
Yeah, in that case, it will be only confined to those segments only.
Sir. So that can explain the lower limb also.
In that case, the lesion has to come down, no? That crossing involvement has to descend from C5 to S1 down.
C81.
Not C81, because right lower limb is also decreased pain, the right side. That cannot be explained by a segmental involvement up to D1.
Okay.
Can be bilateral cervical contraction.
That's possible. But the only thing is, see, main element findings on the right side, but the tract lesion on the left side. It does not go together.
No, those pain fibers which are on the right side, it has to be on the right side anyway, and then only cross to the left. So
that's what Dr. Parmeshwar was telling. In that case, you can explain the pain loss in the right upper limb. But how to explain the pain loss and temperature loss in the right side of the abdomen and right lower limb?
Yeah, that's there on the left side also. The right upper limb pain sensation impairment can be explained by the right sided lesion, and the left side
has to be brought to the contralateral side and affect the spinothalamic tract alone.
Sir, this will get ischemic myelopathy. Sir,
and you
minimal on the left hand, very minimal. Maximum on the right side.
Sir, is it possible to have a ischemic myelopathy involving multiple segments? Say 6, 7, 8, mainly 7, 8, T1 on the right side, and something like a syringomyelia, which is predominantly involved in the sensory tract on the left side, something like a.
That, see, theoretically you're all right, but the thing is that only thing it is slightly not a common thing which you see, not very sound to logic, because see, one syringomyelia only affecting on the spinal diameter on the right side, on the right side, so it's not gelled together.
Sir, or is it, as Joy was saying, it could be a cervical compressive myelopathy with a pseudo syringomyelic type of.
Again, this is the same problem. Lesion is extensive. C5, the whole right upper limb is weak with a reflexia. Okay, but
intramedullary lesion extension bilaterally, sir.
Yeah, well, nobody say intramedullary. You always, this is the problem with intramedullary. You cannot explain the loss of spinal thalamic loss of sensation the right hand from the body.
No, extending bilaterally, sir, involving the left spinothalamic tract.
That is where they were all telling. But see, lemon lesion on the right side, but all that lesion up to the right thalamic tract, and you expect pain loss on the left side. In the same side is lost, entire load. That's the thing, odd point. Now go back to the history once again. There is something in the history. And the history once again. Because the right limb remains static. In one episode of transient loss of consciousness with dysarthria. Now, 1 week back, this numbness occurred 1 week back. And the change in the voice occurred along with that, which improved. But the numbness is persisting.
That could be a left.
Could be TA, so it is not related to the present issue, sir.
Yeah, exactly. That's exactly what I think. See, the evolution also you have to take into consideration. So let's see, that's where something may be affected on the maybe left lateral medulla or left cervical cord. We don't know. So what investigation you need?
In that case, what's the previous cause for the upper limb weak?
That may be something different. That remained occurred 8 months back and remained static, did not progress at all, didn't improve also.
So what is that thing different? It's
I mean, again, anti-constant disease, maybe a motor neuron disease, but there's no progression. Something like ischemic myelopathy, we don't know. We have to think without investigation. One thing is sure, both are different. The evaluation is different. One is acute with the recovery, the other is with remaining static.
Could that be a plexopathy, brachial plexopathy?
Yes, very well. Could be very well a plexopathy also. But you never complain of pain or anything.
So the present decrease in pain temperature could be because of the previous stroke-like episode.
Yeah, but that numbness came only now, 1 week back. So that could explain that thing, loss of pain and thing. The weakness was there 8 months back. This is 1 week only. Okay. In fact, this patient when he came, he had came with the cervical spine MR, which is taken earlier. This is the picture which they plotted with the patient. This sagittal cut. This is the axial cut. I'll go one by one. A better picture later on. This is the one which brought with the patient. There is some hyperdensity within the cord in the area console. Here also you can find hyperdensity within the cord here. So what is the reason? So the problem is, okay, the previous wasting had been there, that is the previous MRI was taken, which shows only mild hyperdensity in the cord, which may or may not be significant for a patient. Still, that does not exclude anti-console disease or ischemic myelopathy may be possible. But we need something to look for the numbness on the right side of the body, which has happened recently. So before that, what else you need to find? Let's sort out one by one. Numbness, second is weakness on the right side. So you need an electrodiagnostic study was done. This is the NCV. Right up here, normal. Median ulnar normal. What else you need? You want to based on the EMG. So EMG was that. Look at the EMG. This is the right FDI. There is no spontaneous activity. Look at the motor unit. That is now come to the APB. No spontaneous activity. There is varying frequency with the large amplitude potential. Equation difference. Deltoid normal. No spontaneous activity, but potential is also normal. Right tibialis and no spontaneous activity. Unit normal. Normal intervals. And to the left in FT. That showed again no spontaneous activity. It's slightly larger than normal. On the other hand, left APB showed occasional fasciculation, very few fasciculation. One fasciculation came, that's all. That's another one. Large amplitude potential mechanical sector. Left base. So EMG shows no active denervation. Chronic denervation in the form of large amplitude MUPs with increased firing frequency, the right FDI, right APB, and left APB. Occasional fasciculation in left APB. Normal EMG from the right deltoid and right tibialis angle. Normal EMG from the left FDI, APB, and left deltoid. This APB has to be wrong. There is some occasional So, what is the diagnosis now? Regarding the increasing and weakness of right thing. That means it's not an ongoing degeneration like a motor neuron disease. There is no active relations. It is diagnosed in any muscle. Only occasional one fasciculation. And the shows early evidence of denervation. That should make you think that it is not a degenerative disease, but something like a ischemic malady. You have to take a repeat MRI also. So MRI brain was taken to find out the numbness. You can sense some hypertension in the left lateral medulla. There is a diffusion. Some hyperintensity you can make out there. This is the play. Sorry, this is the diffusion, otherwise the play. You can see that this hyperintensity, just middle part of the middle are there. This is it's some suspicion here on the left side of the middle. It's obvious. But look at the T2. See that? See the hyperdensity? Just anterior to the cerebellar peduncle, just cutting only the lateral spinal element. It is affecting only the spinal element there. That is why he has got decreased pain and temperature on the right half of the body. Left lateral medulla, sparing the ICP, sparing the inferior, it's only that is affected. Previously, we used to call it pseudospinal type of sensory loss in that. That is the one. Skip. Did angio. So the angio showed the left absent, left, I mean, but it is not seen at all here on the left side. Right side is left, but it is not seen. This there is seen. Again, left vertical is not seen. So, anything else you need now? So we know what is explanation for the loss of pain on the right side of the body. It's in part confined to the lateral spinal element tract in the medulla. So called pseudospinal sensory loss. Then coming to the anterior constant loss, which happened 8 months back, relatively static. Then what could be the reason for that?
Old brachioneuritis with atrophy.
Pardon?
Old brachioneuritis with atrophy.
That's a possibility. That's a possibility. Because only thing he had the presentation was there is no pain and onset. But then not the usual type of brachial amyotrophy. Because usually, you know, the your common muscles have a deltoid supine plus spinatus. And here the pattern is very typical of anterior constant. Because you know the reason why. If you look very carefully, his wrist flexion is weak, grossly weak, but finger flexors are normal. That pattern is typical of anterior constant. It does not fit in with the nerve or a root distribution. Theoretically, possibly with plexus involvement, that can have involvement more favor anterior constant. Understood? The flexors have normal power, but wrist flexion is weak. Part of the patchy involvement of the myotome, patchy involvement of the nerve distribution, through a nerve or a root. So MRI cervical spine was repeated. Is this see the hyperdensity within the cord? Previous MRI brought by the patient not a good quality. So repeat it again. See, you can see the hyperdensity in the anterior cord cell there. Show the axial cut.
There's some hyperdensity within the cord.
Axial T2. Sorry. This is a snake type appearance coming in between. There it is seen, hyperdensity in the anterior consonants. One more cut, you can again see the anterior consonant hyperdensity there. This hyperdensity, this you can see the hyperdensity there. That one. And this is the hyperdensity there. Dorsal spine was so left lateral medullary syndrome, in fact, compared as per the limited pseudospinal form, and brachial amyotrophy due to most likely ischemic and cerebral. That's the diagnosis which I have kept. Whether it's a progressive disease, no evidence of any progression. There could be a brachial plexitis. The possibilities cannot be ruled out. It seems less likely in view of the absence of pain and thoughts. So, any questions?
Sir, in this age group, we will suspect, is this Hirayama, sir?
That is, if you ask me, this is not the age group of Hirayama. It usually starts in the age group of, say, the juvenile onset. And can remain for long period of time throughout the life. So if the history had dated back to the juvenile period, I think it is Hirayama. Otherwise, don't call it as Hirayama. Moreover, it is not the classical presentation of Hirayama. The muscles affected is the small muscles affected, the lateral part is affected more than the medial part. The thenar is more affected, and the classical oblique atrophy of the forearm. It's not classical Hirayama. And moreover, the MRI did not show any features sensitive of impairment.
So, cause of ischemic myelopathy.
Most likely ischemic myelopathy. Because we found anti-hypertonicity in the anterior consils, the spinal cord.
Cause of ischemic myelopathy.
More like many times it's a spondylotic ischemic myelopathy, radicular artery compromise. It's a commonest cause.
Sir, one doubt, sir. Sir, why is that we did not get any denervation changes in the form of fibrillation?
Because that's not a progressive one. This has happened earlier and that's all. It's not a progressive one. Ischemic insult has occurred at one time and remained damaged, disturbed. It's a sequelae of the chronic anticonstant loss. That is, you get large amplitude potential because of the chronic denervation. No active denervation. Active denervation is evidenced by the fibrillations and vacillations. Mainly fibrillation. There's no fibrillation in any of the muscles. That shows it is not an active denervation. This anticonstant insult has occurred. Yeah.
Okay. So shall we do an MRI flexion extension that dynamic?
Yeah, you could have done that.
In?
I could have done that, but the presentation was little odd. That's the age group and everything was not fitting with. That is right. And we found an explanation in this cord itself. Snake appearance. Snake appearance can also occur in the it's not against.
The right side, which anti-cells are involved, sir, with roots?
Cells. Here mainly in the segment, mainly in the segments of C, with the flexus and dorsal wrist is affected. That is, a CA-D1 segment is affected maximum, and C7 also. C1 is triceps is affected. But remember, in anterior console, it's not fitting with the segmental pattern, only patchy affection within the segment. Here, triceps is weakly so much wasted, but the finger extensions are not affected. So you can't call truly C7 segment. It's only patchy affection within this. If you diagnose the anterior disease, localized to the anteroconstant disease, the involvement should not conform to a segmental or a root pattern or a nerve pattern. Only some of the muscles within that segment is affected, some of the muscles in that other segment is affected. So-called patchy involvement is the clue, but this is and here, you remember the flexion wall of the wrist was weak. Finger is normal power. See, that is the same segment is supplying there. But only one of the superior muscles are affected.
Doubt, sir. Sir, if the radical is involved, so suppose the C7 radical involved, does that means that all the muscles supplied by that root should be equally weak?
No, it should not be equally weak. Some muscles may be more affected than the other. But
so there also patchiness can occur, is it?
But the patchiness is to this extent. See, you can have mild disparity. One muscle may be more affected than the other. For example, C7 root, the triceps may be normal, maximum weakness by the finger extensions. Because that muscle is more vulnerable, more The other has got a more of supply from the C7 root. So partial involvement can only affect some of the muscles more than the other. But a significant affection of one group with the total sparing of that the muscle supply same route, you take away from the radical.
Okay.
Okay.
So what was the treatment offered for this patient, sir?
This patient I put him on, I said, for the ischemic, nothing can be done, put him on aspirin and saturation to wear collar or to travel. But as the spinal thalamic tract, I mean, already it's because he's got a stroke, he's got lung part. So that workup we are doing, treating as a stroke, another thing. For the ischemic myelopathy, nothing.
Sorry, EMG wise, any way to differentiate with brachial hematrophy versus cervical ischemic myelopathy?
No, both will show denervation, chronic denervation. Because
any way to differentiate, sir?
Yeah, no. See, brachial hematrophy, the classical neurologic hematrophy is also an axonal. Axonic versus anticonstal electrophysiologically you can't differentiate. Both are the same. Ongoing denervation you can find out by fibrillations and reversifications. Okay.
Maybe if we take the MRI of the nerve, this thing, some hyperintensity can.
No, but already we found hyperintensity in the anticonstal. Then why do we take in this thing? Okay. And the involvement is not a patchy involvement.
Yes.
Okay, shall we stop?
Here there is left vertebral artery, there is some problem in the angiogram.
Yeah, there's responsible for the pulmonary infarct.
Yeah. And the anterospinal artery is from the vertebral arteries.
Yeah, because the vertebral itself is not seen. The anterospinal not pica is also arrested in the vertebral. So it so happened that the branches got supplied from the contralateral vertebra, some or other. Retrograde flow and got supplied. This is well. You can have a total loss of vertebral, only mild area may be affected. You not have the entire. Okay, shall we stop?
Good night, sir. Good night.
Good night.
Thank you, sir. Good night.
Good night, thank you, sir.
Good night.
Next week onwards, regular meeting. Okay.
Okay, sir. Good night.
Good night.
Thank you very much, sir. Good night.
Good night.